Our first presenter is Dr. Todd Lovegren, prenatal associates here at Methodist Women's Hospital, and is going to be speaking about maternal mortality in the state of Nebraska. Todd serves as the co-medical of Nebraska Perinatal Quality Improvement Collaborative, chair of the Nebraska State Mortality Review Committee. His topic is maternal mortality in Nebraska, trying to hit a moving target. Thank you, Dr. Love.
I am on the State Maternal Mortality Review Committee and there, so depending on questions, there might be some things I might have to defer so I don't cross over those lines. And then I also work with NPEC. I am here speaking on behalf of Dr. Todd Lovegren today. I am me, myself, and I am not representing anyone. I say anything. It was pretty straightforward. Discuss maternal mortality in the state of Nebraska, expound on some particular challenges in addressing maternal mortality in our state, and then reviewing the exceptional progress in breaking down silos to improve maternal care in the state of Nebraska. So about maternal mortality review committees in general. So the first kind of recognizable maternal mortality review committee, which is passed, was in California, and that was our Perinatal Mortality Review Committee, which was first established in 2006. This eventually evolved into what a lot of us have heard of as called the CMQCC. They were kind of the first ones to really pioneer maternal mortality and safety and putting out safety bundles and trying to improve maternal care throughout gestation. So shiny. I mean, we're talking, this is only 19 years old from the time the first one was founded. Nebraska's Maternal Mortality Review Committee was just founded in 2018, so we're only 7 years old. And even now, not all 50 states have a review committee. There's only 46 states. There's a few territories and some other things as well that go through the CDC to help collect their data and report it. But what we're talking about, what we're doing here is fairly new in the concept of medicine. So there's a few things to talk about before we start talking about maternal mortality and deaths. So the first thing is there's a pregnancy-associated death, which essentially just means you were pregnant while you died, but your cause of death was not related to the pregnancy. So you were pregnant, died in a car accident. That would be a pregnancy-associated death. There's a pregnancy-related, or associated being any death that occurred while you're pregnant. A related death would be, say you have an abnormal heart and you got pregnant, it exacerbated your heart disease, and you died because that would be a pregnancy-related death. And then non-related would be you're pregnant at the time of death, but you didn't die due to your pregnancy. So this is kind of the Venn diagram of how these things all overlap. So pregnancy associated but not related, and then pregnancy deaths. So how does our Maternal Mortality Review Committee get the information? How having a death to review? Not a medical institution. We're not a hospital. We don't have the records. So how do we get notified? How do we find out about this? So there's a checkbox on the death certificate that whoever performs the death certificate, if they're pregnant at the time of death, that will be triggered for the state to review it. The state will look over it, rest the death certificate to see if they qualify. That 55-year-old man was not pregnant at the time he died, but we get to review his death certificate anyway. And then we look at causes of death. Was it related to an obstetric event? So they may not have checked the pregnancy box. The code might be for an amniotic fluid embolism. Well, she was probably pregnant if she died from an amniotic fluid embolism, so you can't start requesting records and review for that. And then it gets really thorough, we try to be, so we'll even get to the death certificate to the year since she was pregnant and she's deceased. That is a qualifying death that needs to be reviewed. So we look at fetal death certificates, we look to try and tie all those together to be able to find all of these moms. And then sometimes none of those things work and we find it in a public news report. So if it's just reported in the news, a lot of times our staff will write that down to keep track of that name and then search for that to make sure that it comes through our records over the course of the review. What don't we get? If a Nebraska resident dies out of state, this can be really difficult because we'll have all the records in state for their prenatal care, but we don't have any agreements in place with neighboring states to share medical information. So if that mom happens to go get taken across the street to Council Bluffs. She dies in Iowa. To share the records with us, so we'll have no understanding of that. So a lot of times it makes it hard to complete our reviews because we can't get complete information. Tribal groups, Native American groups often don't share their medical information with us, so their death certificates still go on file in the state. However, when we reach out to them to try and get information, a lot of times we don't have a sharing agreement right now, so that information will not transfer. And then there's records we don't know to ask for. So if the patient was receiving mental health services and there's no documentation in the obstetric records, there's no documentation to be found to tell us who they were seeing, or when they were seeing, or what they were seeing them for, we don't know to request those records. We don't know to get those records. So we kind of have to follow the breadcrumb trail in our records to find out care people were receiving. So what kind of records do we review? And we'll get everything from prenatal records all the way up to CFS reports, police reports, autopsy. There's a tool put out by the CDC called Community Vital Signs that we utilize to kind of look at social determinants of health. So that's what this looks like. It kind of gives you an idea of, based on their zip code, what their risks look like. Bad, green is good. So I removed all of the identifying information or all the information from this slide, but this is an example of it. But this is a lot of times what the report looks like. And if you zoom in on these things, it'll be like number of obstetric providers in the region, housing insecurity, food security, things like that. So you get an idea of what the average person living where this person lived, what their risks look like. So what do patterns of deliveries and deaths look like in the state of Nebraska? So first off, 77% of all births in the state of Nebraska. So there's about 25,000 births a year. We'll say 24,000 since this is going to be like 75%. So that means we've got somewhere in the neighborhood of, what would that be? 16, 17,000 births in the metropolitan areas. The rest are all in rural areas. But when you look at the obstetric providers, that means essentially a quarter of all the births in Nebraska are being done by 8% of the providers. So the providers who are working out in rural areas are working extremely how we're working in the city. When we look at deaths, 66% of those occur in metropolitan areas. Now you look at this and say, okay, that seems about right. When you look at most states and you look at their death rates, they have a higher rate of death in their metropolitan areas. And the reason for that is that patients are getting referred to where they should be for their care. They're dying, hopefully dying in the metropolitan areas. Death. Nebraska is a lot of patients aren't making it to their regional areas of care, and we're seeing more deaths in rural communities where patients aren't quite making that transfer to get to a higher level hospital before the death. That kind of the worst thing, and this is there for those of you that know, there's a rural health transformation grant that's out there to help processes, which is potentially going to give us access to $200 million for programs to improve maternal outcomes. One of the things we would like to address is that 52% of counties in Nebraska are defined as maternity care deserts. So there's varying definitions for this. The March of Dimes, where this slide came from, says this includes counties with no access to birthing hospitals, birth centers, or OB providers within 50 miles. So anything that's red, essentially those individuals that live in those counties are more than about an hour from help. See, there's high rates of uninsured or underinsured. There's limited providers, less than 6 providers. Can you imagine if there were 6 people responsible for this? That is crazy. So you can see that our state essentially follows I-80. That's where all the care is. Then outside of that, you get maternity care. So what does maternal mortality actually look like in the state of Nebraska? You can see from 2014 to 2022, we had 33 pregnancy-related deaths. So these are women who died because we think they died on review of their pregnancy-related condition. Now you'll see a lot of these cells are filled with a dash. It's less than 5. We don't report because of the risk of identification or patients being identifiable. So any cells with a number less than 5 don't get reported. So for several years, we had so few deaths, we couldn't even report how many deaths there actually were. Over the same period of time, there's a total of pregnancy associated deaths. So if you go back to that 33 of them died because of complications from pregnancy. And so you can see our pregnancy-associated mortality ratio, which died while pregnant, was 45 per 10,000 over this report. When we looked at the pregnancy-related mortality ratio, 15. Rank amongst the 30 some states that were reporting at this time. See is I think we came out 23rd. So we're in the bottom third. There's some room for improvement in terms of our maternal mortality. Because when you use the science to really fully evaluate this, one of the things that I think I identified last night is that based on, I think we can conclude that football teams cause increased mortality. So I'm being at Alabama now. When you look at where we're ranked, 23rd out of 39, this is a letter grade. And our preterm birth rate as a state, March of Dimes has given us so we have some room for improvement from a maternal child wellness standpoint. Certainly some room for improvement from a maternal mortality standpoint. So when we take these deaths, and now all these, because of the numbers, we reported all on pregnancy-associated deaths. So these aren't necessarily moms who died due to pregnancy. These are moms who also died in car accidents and other issues. But there is correlation between pregnancy-associated death and pregnancy-related death. So we reported on all of our PAMR mortality data. And so one of the things you see is same things get reflected in the national data. Death among our non-Hispanic Black population. We see higher rates of death in our rural population, 63.9. The higher rates in the African American population, our lowest rate was Hispanic population at 27.1. The African American or non-Hispanic Black population was over three times that number. So some big differences amongst groups. In terms of cause of death for these pregnancy-associated deaths, you can see that about 42% were medical, a small number of suicides in the neighborhood of 14%, and then 45% were accidental, which was almost exclusively accidents. So why is this a moving target? Why is it a hard target to hit in terms of what your causes of mortality are? Well, one, we don't report less than 5, so the public doesn't hear about a lot of these maternal deaths, or it doesn't have a chance to review what's happening in the state of Nebraska or understand it. But there's also been some changes in the identification of reported causes of maternal mortality. So when we review a death, so we'll say, well, I'll give you an example here in a few minutes, but one of the philosophical problems we're having is, what do you cause the cause of death when you report this out as a maternal death? To decide, because how you report it's going to decide how you try to intervene in that death. Okay, so here's my example. So 18-week twin presents with cervical insufficiency. She promptly delivers. How do you report the death for that child? And I literally, unfortunately, had to fill out a death certificate like this just in the last couple weeks. So those 18-week twins come in and they die. The reported death will be extreme prematurity, right? But when we look at it, well, we know this was cervical insufficiency, twin gestation. That was really what led to that cause of death. So when you're reporting a cause of death, if we report that as extreme prematurity, do you focus your resources on treating prematurity? Or do you focus your resources earlier when you could have prevented the premature birth, when you could have done cervical length screening, had better care? Maybe she has lack of access to housing or food. Do you address those things before it results in preterm birth, or do you document this as a preterm birth and focus your resources on trying to save 18-weekers? You know, which of those is more viable as a strategy? Well, I would argue that prevention is more viable as a strategy. And so what's evolving is, currently when we look at maternal mortality, if mom dies after an eclamptic seizure, if she dies from cardiomyopathy, stroke, MI, we'll read our case vignette, we'll read our abstracted report that Kayla gives us. And at the end of it, what happens is when you read through the story, you get to the final cause of mom's death, and we report that cause of death. She died from an eclamptic seizure, she died from a stroke, she died from an MI, and that gets reported as the cause of death. And so when you see the CDC report at the end of the year from all the states aggregated together, it'll say we had this many moms die from a myocardial infarction, we had this many moms die from a stroke. Great. But as obstetricians, are we going to come up with better ways to take care of a stroke? Are we going to come up with better ways to take care of a heart attack? And what happens is there were 13 MMRCs that dove into some deaths due to this. And what they found was up to 30 or 40% of their causes of death were related to hypertension. When they looked at their cardiomyopathy, they saw room for intervention way earlier on, just when these moms were hypertensive. So here's an example of how this works. An idea again. So 24-year-old Kiche speaking, first pregnancy, 22 weeks, comes in with vague abdominal symptoms and flank pain, but they struggle to obtain a history from the family and patient due to a language barrier. Patient was seen in the same emergency department with a UTI 5 days ago and a history of recurrent UTI. Later, while they're completing her evaluation, beginning her treatment in the ED, a code blue is called. They're unable to resuscitate her, and McCain, our abstractor for the MMRC, has done is she's brought back a DC called. Now, as we read these vignettes, and you read this vignette and you finish, you're like, oh, she died of sepsis. This was visible, preventable. There was plenty of room for improvement. But Kayla lays out this chain, and she lays out each of these steps, each of these risk factors. And as you go back and look at this, so this death would get reported as a sepsis death. Wanted to intervene in her outcome, would you start by treating sepsis better, or would you start by better obstetric care? Recognize the patient with recurrent UTIs, put her on prophylactic antibiotics. Would you maybe talk about follow-up after her ED visit 5 days ago to make sure she was able to fill her antibiotic? Is she taking her antibiotic? So there was lots of room for improvement in this case, but sentences, and I've shown you this chain, and when you talk about it from a philosophical standpoint, it's really easy to see that if we report this as a sepsis death, which is what it was, to enact change at the level of care. So one of the things we're doing at the Nebraska MMRC is we're kind of backing up and we're looking for that first chain that we can really make a big impact, and talking about reporting that as our cause of death, is the cause of maternal mortality, resources, and making recommendations to legislation and obstetric providers that we're targeting the right thing where we can have an impact. To have an impact training OBGYNs how to manage end-stage sepsis. But we can definitely have an impact on changing prenatal care, which might even prevent the events from ever happening. Innovation producing change. Again, kind of getting to the philosophical question of remove focus from the endpoint and highlight prevention intervention. My kids help me, and they always help me find some memes to add to my talks. And so, piranha. You make them proactively. So again, shifting sands. As the change is adopted, I think we'll need to see a shift in reporting. So I think I hope from the CDC standpoint, we get away from talking about the final cause of death, or we report two. We report the final cause of death, and then we back up and report a first interruptible chain in the chain of risk. We actually had the opportunity to present at the Maria meeting, which is the National CDC Maternal Mortality Review Committee. Kayla presented on the chains of risk, and it was really well received. I know she's done a couple talks since then, talking to individual states. So we're really seeing some movement across the country in terms of changing how we report, so we can report on things that are interventionable, things you can act on, things you can do differently to make things better for moms. What about barriers in Nebraska? Small numbers. I've already mentioned it twice. When we have cells that are so small we can't report, it's a benefit that we have so few deaths, but the problem is we're a small state, higher than average rate of maternal mortality, so it still needs to be addressed. And the hard part is we have to wait 5 or 10 years to get aggregate data, so maybe we have enough information to come up with something or come up with a strategy that we can act on. Hard to see improvement. If you have to wait 10 years to get data, you have to wait 10 more years to see if you had an impact, and that's 20 years. That's darn near a career. Cuts. We have a large number of critical access hospitals in the state of Nebraska. So there's 43 total hospitals that participate in NPEC. And right now, with changes in funding, we're at risk for losing 6 of them in the next 12 months. So we're really hoping for that Rural Health Transformation Grant to come through and keep those birthing hospitals open. If we lose 6 birthing hospitals out, expect our jump than that significant amount, because these critical care access hospitals bear capacity. So how's it getting better? The MMRC has grown. I joined, I think I was the 10th member in the second year. I believe. It's now up to 19 members. We have clinical and non-clinical. We have insurance represented. We have lay people. We have community workers. So there's a fantastic relationship that's growing across the community. Life experiences. One of the things we're working on, everything we do, we're legislated through the state. So anything we want to do, approved through legislation, which is a slow rolling stone with moss on it. I'd like to see those relationships grow with neighboring states so we can share information more easily without it being a federal issue. And then we would also like to see patient interviews. So steps off a curb in front of her and is struck. She's killed. We review that case and you look at it and say, she stepped off the curb and just not see the car. She has a history of depression. Did she step off the curb intentionally? Was this a suicide? It's really hard to get that from paper. It's really hard to get that from a few prenatal notes if there's even anything about her mental health status in it. So moving on to patient interviews, it really gives us an opportunity to talk with the family. Did she have some stressor that happened that week? Did she lose her? Some of our patients did CFS come and take one of her own. So getting to patient interviews is a huge step for MMRCs in terms of getting more insight into patient state of mind, patient status, when these things happen. NPEC is making everything better. 43 birthing hospitals in the state of Nebraska. Almost all of these hospitals all of them are involved in at least some of these initiatives to improve quality across our state. And most of them are involved in all of our initiatives. There's the postpartum alert initiative. If anyone's seen the teal wristbands going around, all the pregnant moms are wearing. We've got it going to Methodist now. So that's an awesome thing. We're starting to see lots of good stories come out of that, where moms are being caught and identified as being recently pregnant because they're wearing their wristband. So there's lots of A1 has bundles, AIM does, CMQCC. They all have very similar kind of patient safety bundles that are being rolled out. I'm sure everyone here has heard about this at some point. There's the Title V State Maternal and Child Block Grant. This is a federal grant that you go through and essentially identify a handful of priorities for your state. And I'm happy to say that prenatal care and maternal mortality are high on Nebraska's list in terms of things to improve and target with our Title V grant. So that's way up there. Talked about. There's $5 billion to be divided between 50 states. The amount of rural population in your state, and the maximum you can get from this new fund coming up is about $200 million. So I'm really hoping in the next year or two, everyone here is going to fund it. And Nebraska has lots of opportunity for some ready improvement. And the last thing I'll point out here is that when we talk about these pregnancy-related deaths in the state of Nebraska, after reviewing all of them, we felt 82% of them were preventable. That's a tough number. 4 out of 5 moms who died didn't need to die. And this is right on par with national statistics, and lots of room for improvement. And the first step is being in a room like this, and being in a group, caring about the next steps and caring about our steps in Nebraska from a maternal mortality standpoint and trying to make things better. So I'm going to finish there. I know that's a quick talk about maternal mortality at a state level without stealing from our premier speaker who's here today. Any questions or thoughts?
Dr. Love, quick question. And I know you can't get into the weeds, but what are you seeing when you say 80-85% are preventable? What are you seeing as the primary targets for that prevention? Is this recognition? Is it lack of resources? Is it intervention based? What are you seeing primarily?
I would say we see as gaps in care. That's a big problem with it. So people have really severe diseases, and they'll kind of be they won't really have much medical interaction or cross section with anybody medical for a year and a half, and they'll show up pregnant and kind of the horse is out of the barn. But there'll be a whole bunch of notes from her last delivery or her last pregnancy or from her physicians that said needs to be on 2 forms of contraception, needs to be on 2 forms of contraception, caution about becoming pregnant. There usually is not a formal consult about getting pregnant or not, but there'll be some notes alluding to the fact she shouldn't get pregnant. Then she shows up pregnant. Or there'll be a mom who is seriously ill in the hospital, gets discharged, doesn't have any follow-up, comes back with a critical event. We see a fair number of substance abuse, mental health issues. And again, some of those can be the hardest in terms of calling those pregnancy-related versus pregnancy-associated. There's some states that feel any substance use disorder death should be pregnancy-related because we know pregnancy exacerbates those things. We know pregnancy exacerbates depression, anxiety, exacerbates substance use disorder. But these cases, you go through them, and the question is, this patient was using prior to their conception, they used all the way through their pregnancy, and then they have an event postpartum and they die from it. Do you call that pregnancy-related? So I struggle with it sometimes, saying all of them are pregnancy-related because this patient had consistent use throughout. People who advocate that by calling all of them pregnancy-related, we can improve action on those patients to get them care services. Because we have such a lack of services in our state, it's hard to argue against that if it's going to help get funding for mental health and for substance use disorder treatment.
To introduce our next speaker, Dr. Stephanie Martin. Dr. Martin is board certified in obstetrics and gynecology and maternal fetal medicine. We welcome her from Clinical Concepts in Obstetrics in Scottsdale, Arizona. Dr. Martin has extensive clinical experience in the care of critically ill, pregnant, and postpartum women. She's the author of numerous publications on critical care obstetric topics, including sepsis, maternal cardiac disease, placenta accreta spectrum disorder, maternal cardiac arrest, and obstetric hemorrhage. She is also the co-author of the ACOG Practice Bulletin on Pregnancy and Heart Disease. She served as the medical director for and helped establish the Obstetric Intensive Care Unit at Texas Children's Hospital Pavilion in Houston. And she served on numerous boards. She's done it all. It is my pleasure to introduce Dr. Martin.
Thanks. Okay, good morning. This was Dr. Lovegren's talk was a perfect segue into what we're going to be talking about here. It's challenging to be hearing all this talk about morbidity and mortality. Was feeling because there's a lot of things that are absolutely out of our control. We can't change the geography. We can't change the access. We can't change morbidities that our patients are experiencing. We can't change all of that, but there are things that you can do at the bedside that absolutely do make a difference. So before we're done, you'll have some actionable things that you can take to the bedside and think, what can I do differently tomorrow or today to take better care of my patients and try and decrease the likelihood of some of these things happening to my patients. How many of you have lost a mom in your career, experienced the loss of a patient? Quite frankly. I've experienced a lot of loss of patients during my career. I think it just reflects on the fact that I took too much call. It's not a reflection on me as a clinician, but my first loss as an attending OB out of training was my first day. Literally my first day as an attending. I had a maternal death from amniotic fluid embolism. And that fueled me. It almost made me quit medicine, but it fueled me to really dive deep. I'd always been into the high risk and critical care stuff, but then I got really personally passionate about it. I spent the next several months learning everything I could learn about amniotic fluid embolism. This was in the 90s. There wasn't much out there to learn on amniotic fluid embolism, quite frankly. And 6 months later, I had another one. And we lost the mom and saved the baby. Something from the first one I had, anyway. So my presentation today is a lot of my own personal perspective and experience based on taking care of a lot of high risk and critically ill patients over the years, I've been in a variety of clinical settings, from extremely large medical centers doing 8,500 deliveries a year, being part of 24, 25 MFM practices, to working in very small practices and doing a lot of maternal rural care, flying in small planes to little bitty hospitals to do ultrasounds and see patients and do consults, those kind of things. I've kind of seen the full spectrum of it, and I've experienced that. So that helps me kind of have empathy for everybody in these different settings. Like, there is no one that works harder than a rural health team. I mean, they're doing everything for everybody. I think it's one of the hardest jobs. Whereas in the major medical centers, we get what I call consultamegaly, where we can do a consultant per organ. You've got a urologist and a nephrologist and a cardiologist and a neurologist and a dermatologist and then everything. And then if she starts bleeding after a month in the ICU, they consult the gynecologist because these are. I also am going to share my experience based on reviewing a lot of medical legal cases. So I do a lot of medical legal work in my life. I review a lot of cases, and I tend to get a lot of maternal death or near maternal death cases. And as part of my business, I also go to hospitals all over the country and evaluate their systems and look and see what kind of care they're providing and where their opportunities are. I also help MFMs prepare for the board exam. So based on this, I have a kind of a unique snapshot of what people are doing across the country or not doing across the country. Really clear to me that there are some themes, there are some things that are happening and not happening across the country that really need to change. And it's more than just access. It's more than just obesity that are going on. Focus on. Several years ago, if you have not investigated this series on ProPublica called the Lost Mothers series, I strongly recommend that you do so. These reporters ones to start talking about the maternal mortality crisis in the United States. I was so happy when I saw this first article come out. I couldn't believe it because I felt like I'd been just speaking into the void. Like, no one cared. All anyone cared about was the baby. Everything was about the baby. Even, and this is not to criticize A1. I'm highly active in A1. I'm a member of A1. The high risk and critical care book was a baby. You know, and that just kind of shows you how everything becomes about the baby. And they highlighted this. Focus on the babies leaves the moms in danger. Everything was about the baby. Nothing was about the mom. So this is a story that they told. This is an actual story. I have dozens of others just like it that I could have told, but they did a nice job on it. There's no HIPAA violations here. And this is Lauren and her newborn. She was the last person you would expect to die in childbirth. She was a NICU nurse. She delivered in the hospital where she worked. She had handpicked her OBGYN, was the doctor that took care of everybody in the hospital. You know, think the ones you work with. Who would you let take care of you, right? Everybody knows who they want to work with. Everybody knows who they want taking care of them. And everybody knows who they will never let walk in their door. That's why I've noticed on the, I get asked to do a lot of applying for privileges. They do referrals, or what do you call them? Like, where they say, do you tell us everything you know about this doctor? And one of the questions now is, would you let this person take care of a family member? That's on a lot of them. It's a good question. Anne chose her OB. She had an uncomplicated term vaginal birth. Her husband's an orthopedic surgeon. Like, the most prepared, able to advocate team that you could imagine, right? She has an uncomplicated vaginal birth. An hour and a half later, she's got severe epigastric pain. The husband's like, what the heck is going on? Oh, it's heartburn. Heartburn. Okay. 10 out of 10 pays. She's just pushed out a baby. Saying that the epigastric pain is 10 out of 10. She's severely hypertensive. In fact, she'd been hypertensive the entire time, and no one did a darn thing about it. They didn't acknowledge it. They never worked it up. They never did anything. They didn't order labs now because she had this epigastric pain. The husband is getting concerned, and he's like, look, somebody needs to do something about this. Get somebody at the bedside. So they call, the OB says it's esophagitis, acute postpartum esophagitis. That's a thing. So they call a gastroenterologist. This is a real story, and y'all are thinking this would never happen. This would never happen. I'm telling you, I've got many, many more. I could go all day on cases. The gastroenterologist just gives her pain meds. Frustrated. Why is nobody doing anything? So he calls a trauma surgeon friend in another hospital who says, what the heck is going on? She's got HELP syndrome. It took an orthopod to diagnose HELP syndrome. Okay? You better make sure they do something about this. All right? Caregivers are like, she's fine. We don't need to monitor her blood pressure. We know it's high. What's the point? Stuff all the time. Getting them to do something because she's in so much. 197 over 117. Now she's got a headache. Are we surprised? He studied his wife's face. He realized something had changed. She suddenly looks really calm and comfortable, like she's trying to go to sleep. She gave him a little smile, but only the right side of her mouth moved. What happened? Lauren suddenly seemed to realize what was happening. She looked at me and said, I'm afraid and I love you. Those were basically her last words. And now a neurosurgeon confirms she's had HELP syndrome. But they can't do surgery because she's severely thrombocytopenic and they don't have platelets. Could they have anticipated this? Could they have planned for this and gotten platelets from somewhere else? Could they have transferred her to a different level of care? They have a neurosurgeon and a gastroenterologist who's seeing a postpartum patient. I'm thinking they don't need to transfer her, but you get my point. Hours go by doing nothing, and now she's brain dead. Removed from life support, postpartum day 1. Preventable death. Yes? From one of the most common complications of pregnancy in a high-level facility with 2 educated healthcare providers, the last person you would expect to die. This kind of stuff is happening all the time all over the United States. That's him with his daughter, and that was her a few years afterwards. This was about 10 years ago. It's last week, it's very similar. So, as Dr. Lundgren pointed out in his talk, the definitions of maternal mortality are specific but commonly confused. So you're going to see different numbers. You'll see different ratios. Don't get obsessed over those numbers. Just know it's way higher than it ought to be, and it needs to get better. Okay? It peaked in 2021 from the Delta wave of COVID, but you can see that it's pretty consistently bad. Numbers. So these ratios of 18 per 100,000, that's about 700 women dying. We are on par with Palestine for our maternal mortality, and Chile. That's where we sit. We are winning the race. We are worse than every other developed country in the world by a month. You can sit and argue all day long because like a year and a half ago, it was like, oh, our maternal mortality rate is just not as bad as everybody says it is. Okay, maybe the number's not right, but it's bad, guys. And it's worse than everybody else. There's just no room for debate there. What the exact numbers are, we need to do a better job. We need to know more about this, but we're winning this race. And Black women die at much, much higher rates than everybody else. And you start adding age into the factor and it gets terrifying. Add comorbidities on top of that. A Black woman in her 40s with hypertension and the mortality rates. In the United States, this is an interactive map that you can find online where you can hover over the states and it'll tell you what everybody's maternal mortality rate is. Okay, and I'm using these terms rate, ratio. They're wrong. I'm sure I'm misspeaking, but going after is the highest at 82 per 100,000. California is the lowest. They hover. This says about 10 per 100,000. At one point, they were like 6.5. They're doing the best. Why is California doing better than all of us? Standardization. You've all heard of the CMQCC? So they have standardized processes. That's just a piece of it, but it's a major piece of it. They do a lot of other things as well. But they have statewide initiatives to standardize their processes. California is about the size of the United Kingdom. The rate is very similar. So it is very difficult to standardize things across the United States for a whole lot of reasons. You can see, I was telling him, you know, the grayed out states right there, we don't have data on those states because the deaths are too few to report, so that for de-identification purposes, they're not reported. So I couldn't tell you what Nebraska's is, but you can see the dark numbers are bad. And the 6 states in the top 10 also have the highest rates of Black births. Probably not a coincidence. Lots of factors go into this. We'll talk a little bit about some of those, but being a woman in the South is pretty dangerous to have a baby these days. Most lay people, some of you as well. But I think when you think about a maternal death, we think about someone dying either with the baby in them, literally still in the delivery room. But the majority, in fact, 2/3 are happening after they go home from the hospital. And that's because cardiac is right up at the top. And cardiac deaths tend to not show up until a little bit later. So 2/3 are happening after they go home from the hospital. Overall, now again, just like the numbers, you can look, and that's going to shift year to year to year. And the reason it's a little bit confusing is because we're not getting one single data set from the entire nation, all 50 states. We're not. That doesn't exist. What we're getting are compilations of different maternal mortality review committees over varying periods of time. So it depends on which data source you quote. I just want you to remember concepts. I don't think it's important to know the exact numbers and what's jockeying for #1 this year, and next year it's going to be #2. Overall, we're talking about heart disease and stroke, particularly in terms of preventable deaths. At delivery, it's all the stuff you would imagine. It's hemorrhage, it's amniotic fluid embolism, etc. The longer they get from birth, the more likely you're going to have things like hypertension, infection, and cardiomyopathies that are causing these deaths. This is one looking at 2 years of a maternal mortality review committees of many states, but not all the states, okay? And you can see that suicide and substance use disorder, mental health is a large proportion, but we're still dealing with cardiac and hemorrhage. I have a case right now, weeks ago, of a mom, grand multip, 11 babies, who showed up in a rural emergency department that doesn't do obstetric services, who was in hemorrhagic shock when she presented because she bled at home. They diagnose her with hemorrhagic shock, and they don't give her the 4 units of blood that are in their hospital, and she dies. Did y'all know that military deaths are not reported? If you are a military mom and you deliver in the military health system, that's not counted. Because their health system is, I don't know exactly why, but what one of the military that know, their military health record system is completely separate and independent, and the government doesn't want to essentially join them in any way so that it can be monitored, tracked, whatever. I don't know the whole reasons, but bottom line is we're not counting. So when I tell you we don't actually know how many women are dying in the United States, don't. Pick a number, but all the numbers are consistent. Well over 80% of deaths are preventable. The most recent data from the CDC that just got published, I don't know, a month ago, it's 87%. And if you look by cause, the percentages change, but the reality is the vast majority of maternal deaths are preventable. So this is good news because that means there's something we can do, but it's also bad news because it means they didn't have to die. You have opportunity here. There is huge opportunity here, and it's not going to take an entire restructuring of the whole medical system to make an impact. That will make an impact. Require them to make an impact, in my opinion. If you want to strike fear in the heart of an intensive care unit, bring a newborn into the ICU. Bring a giraffe. We'll see who calls in sick those days. Okay. Okay, I'll tell a funny story. This is a true story. I tell it a lot. Brain. I'm one of those weird people who likes the ICU. And I like going to the ICU. I like having consults in the ICU, all that stuff. And this was earlier in my career. We were still carrying pagers. No one had cell phones, anything. And I had a patient in the ICU who was postpartum. And this is to help you understand. Most of you in the room are probably going to be pretty intimidated by the ICU. Anybody ever, any ICU nurses here? Former, current? You're like, heck no. Incredibly smart people. They are incredibly confident. They are incredibly capable of acting independently and doing a lot of critical thinking in really high risk situations, just like everybody else in this room. Okay, so you terrify them and they terrify you. Okay, and here's an example. So I had this postpartum ICU patient. She was nonverbal. And I don't even remember why she was in the ICU. It was probably a hypertensive issue, but I don't remember exactly the details. And I was like, okay, call me if you need me. Down, delivery, and I get a 911 on my pager. I don't even call ICU because I know it's going to take me forever. It's 6 floors up. I book it up there. I get up to the ICU. I come through, and I look down the hall, and there's all those glass doors, sliding doors everywhere, right? And there's just a crowd quietly staring into her room, like 10 people, just not doing anything, just staring in the room. And I was like, I missed it. Over, and I look in the room, and the patient's sitting up in bed, and everyone's staring at her, and she's staring at them like there's absolutely nothing happened, and she's not dead. Nurse pulls me aside, and she's like, Dr. Martin, we think her uterus fell out. Sorry. Yes. Pretty sure it didn't fall out, but if it did, I can put it back. Okay. Walk in, I pull back the sheets. It's her labia. Because she is massively edematous. This is why I think it was probably a hypertensive disorder she was in the ICU with. She was massively edematous. They did not know what they were seeing. They were terrified and completely shut down by this. Whereas any nurse in this room would have been like, get out of my way. Like, I got this, right? We have a code on L&D, and we're panicking, and they're like, get out of my way, I got this, right? So different worlds, we have to work together. I'm in ICU right here. Okay, if we're only going to talk about mortality, we're missing the picture here. All right, yes, about 700 women roughly die every year in the United States, but at least 100 times that try to die every year in the United States. You know them. They're the ones who go home, or they're at a rehab facility because they had a stroke, or they lost fingers from septic shock, or they got 30 units, whatever the case may be. They came close, but they didn't die. We have to count them too. And it wasn't that long ago we weren't counting them at all. So now that we're counting the severe maternal morbidity, we can pay better attention and start making an impact there. Because if you make an impact there, then you will make an impact on death. This is a group, I was lucky enough to be part of this group. I was not part of this publication. I joined them right when this was being submitted for publication, but I'm a subject matter expert for Premier. This was done with Department of HHS, looking at inpatient morbidity and mortality. And basically what we found here is that mortality is going down in the hospital. We're doing a better job in the hospital, and I don't think people talk about that enough. Like, mortality is bad across the country, but in the hospital, mortality is consistently going down. But what is going up is morbidity. And morbidity are all the things that lead to death, right? And I think it's going up because we're doing a better job saving moms. So they're living to have the morbidity that we're counting. If they die, we're not going to count that morbidity as they're going to have fewer morbidities if they die before they get those morbidities, right? Someone dies on labor and delivery from hemorrhage before she goes to the ICU with ARDS and shock and ventilator dependent and all the things that happen. Those are all the morbidities that get counted. So we are doing a better job. So if you interrupt the morbidities before that, then you're going to prevent. And that you can measure. And it's easier to measure that than it is to try and wait for a death, especially in states like Nebraska, where you're having handfuls of deaths instead of dozens of deaths, right? You never know what your things are your efforts are making. So I've noticed some themes in preventability from my experience that I've shared and from my perspective, I think are really big, and they're supported by what the literature is showing, but I'm focusing on the things that you guys can do, like some themes of preventability that are actionable, not just hospitals are closing and our patients are getting sicker, okay? Failure to recognize early warning signs. If I look at one more chart that blames the patient for being anxious right before she dies, I'm going to hurt somebody. Anxiety is a symptom of lack of perfusion. Women do not get anxious magically when they show up for labor and delivery. I understand there's such a thing as anxiety disorder, but when you look at, and I'm sure you probably see this a lot in the cases that you review too, where anxiety and dismissal of symptoms is very, very common. Women don't just drop dead, with very rare exceptions, and that's amniotic fluid embolism. Amniotic fluid embolism is extremely rare and not the most common cause of death. It's hemorrhage, it's cardiac, it's infection, and those don't just happen in a minute. Early warning criteria are a of parameters that include vital signs, clinical findings that tell you things are going in the wrong direction. Do something about this. It's more than an order set. This is not just call me if her blood pressure is above 140/90. This is if we have the one or more of these defined criteria, these actions need to take place, including a bedside assessment. Okay? This helps the nurses, it helps the physicians, it helps the midwives, it helps everybody. This is just one example of a study that looks at the different contributing factors. And there's many, many, many. But in California, because they've done a lot of work improving this, right? Delayed response to clinical warning signs was one of the top things that contributed. And this is just consistent. When you looked at the UK data, because the UK was one of the first to implement maternal early warning criteria, they started in 2007. And delayed recognition was one of the big things then, and it continues to be a big thing now. Why? Because we're human beings, and we normalize the abnormal. Normalizing the abnormal is essentially where you do something enough times and nothing bad happens, therefore it becomes okay to continue to do it. Okay? You speed enough times, you don't get a ticket on the freeway until you get that ticket. Then you're going to drive slow for the next few days. From personal experience. The more you do this, then the easier it gets to deviate from other practices. So in medicine, this looks like maybe not treating severe hypertension within an hour, and she doesn't have a stroke and she goes home fine and everything turns out okay. All right, what was the big deal? She's asymptomatic. Everybody panicking. I've seen this a million times. Nothing bad ever happens. That's a classic example. Then if you do that, then it becomes easier the next. So, well, why do I need to start antibiotics in this amount of time? She's going to be fine. Everything's fine. Calm down. Right? So it's easier to kind of let it bleed into other standards. And then we don't have any standards anymore. In healthcare, this is actually a healthcare study. Why do we do it? Nobody comes to the unit thinking, screw that protocol. I'm not paying attention to that protocol. Well, maybe, I mean, there's maybe some protocols where you're not going to do that, but it's because we think that rules are stupid and inefficient. Why? Because many of the rules are stupid. How many of you have seen a bed sore in a laboring patient? 10 scores. And inefficient and a colossal waste of your time. But you have to do it. Sometimes your work roles have to be met by breaking rules. I'll give you an example. I went to view one facility where we evaluated everything that they were doing. It was a level 1 facility, rural facility, wonderful team of people. And as we're talking to the nurses and walking around, we realized that all the nurses are carrying turb in their pockets. Okay. I'm like, this is not okay. Why are they carrying turb in their pockets? And it's because they had an OB who insisted on using inappropriate doses of misoprostol for labor induction. And the nurses had to be prepared for all the crazy things they were going to see on that monitor that they were going to need to deal with. So they just carried turb in their pocket, right? So that's what happens. So we got to the root of the matter, educated the teams, made sure the protocol was enforced, blah, 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 blah. You get it, right? Imperfect knowledge. Knowledge is a problem. You have to understand preeclampsia in order to know that epigastric pain and headache are signs of preeclampsia. You have to have knowledge, okay? That's a basic. And then fear of speaking up. All right. If you're the nurse and you call at 2 in the morning for an order and you get chewed out, or you're treated rudely, or you just don't get the response, or you can't get a hold of somebody, or you report physician behavior up the chain of command and then it bounces back on you, what are you going to do the next time? You're not going to speak up, right? And same for physicians. Like, we get frustrated and we go to administration and start complaining about things and wanting things to change, and nothing happens, and then we maybe lose a contract, or call terms change or something. We're maybe going to just stop fighting the system, right? But it's more than just standardizing vital signs. You also have to say, if this, then that. If you have abnormal vitals, then you have to do something about it. And as a nurse at the bedside, that gives you power, because you don't have to know why things are happening. Nurses do not diagnose. Nurses assess and communicate and implement plans of care, right? So you're not required to diagnose preeclampsia, but you've got to do your assessment. You've got to know about preeclampsia and communicate it. But if you're communicating and there's no standardized response that needs to take place, you may know that something needs to happen. You may not know exactly what, but if you're not getting it, what's backing you up? Then it becomes a nurse versus doctor instead of a, this is how we do things, right? So having policies that say this is what happens. If her blood pressure is this, a provider will come to the bedside within X amount of time. These medications will be administered within X amount of time. If you don't, well, it's a very simple escalation. Simple escalation. So you've got to have prompt reporting, and you've got to have an effective policy to implement. Okay, I just want to take a minute and admire my little ChatGPT image right here. How many prompts I had to give ChatGPT to get this picture. It was a little bit interesting. Like, I don't know what that's up with that stethoscope. I don't know, the whole thing. Like, yeah. What I did do was ask it to show somebody getting chest compressions while pregnant, like in cardiac arrest. That's how it started. And when I couldn't get them to stop doing chest compressions on the bladder, was when I gave up and I was like, just show, whatever. So very happy to get this image. You can't manage sick moms from the phone. You can't. Now, if you have hospitalists, it makes things a lot easier, but you got to make sure your hospitalists know their role and they're not banned from seeing patients and all these other kind of things. You got to have clarity about what their role is. If you standardize, the data are pretty clear, you're going to, morbidity goes down, and if you decrease morbidity, you're going to decrease mortality. Delay. If you don't have a standardized recognition system, you're going to have delay in everything that you do from there on out. It's just facts. So from some of the things that I see in delay is failure to transfer. And that doesn't necessarily mean going to another hospital. It might mean going to the right location in your own hospital. Like, you can't have two standards of care in your hospital. If she meets criteria for intensive care, she needs to be in an intensive care setting, not in labor and delivery, okay? Delayed consultations or delayed surgical intervention, especially when you have them at the bedside. I reviewed one case. Well, I've got multiple cases with hospitalists going at it with OBs, but one case in particular where the hospitalist, basically the nurse had a hemorrhaging postpartum patient, and the hospitalist was at the bedside and was not doing anything for the patient and was telling the nurse, you better tell that OB to get in here right now or I'm going to take her patient to the OR. Like it was a threat. Well, take the patient to the OR. Like the patient needed to go to the OR. The patient needed blood. That patient didn't die, but she lost 3 limbs. Resistance to involving critical care or calling a rapid response. I have another case of a young mom who was profoundly tachycardic in labor and delivery for a couple of hours, being managed by with hypoxic and short of breath on oxygen, being managed by the midwife, no RRT called. Died, teenager. Failure to transfer to a higher level facility when needed, or waiting too long, especially if you're in a rural environment. You cannot wait till the last minute. You have to do it early, maybe even before you think she really needs to go, depending on your circumstances. How long does it take to get transport? What's the weather? All those things, right? Several years ago, started in 2015 and then 2019, the American College of OBGYN and Society for Maternal Fetal Medicine decided to provide some standardization for institutions and what they can actually take care of. So it's the levels of maternal care. Prior to this, I would ask people, what's your level of care? And they would say, oh, we're level 3. I'd say, no, not your neonatal level of care. What's your maternal level of care? And they would say, oh, we have really sick patients, so we're level 3. Your level of care is not defined by how sick your patients are. It's defined by how prepared you are to care for those sick patients. We flip it. In OB, we think we have sick patients, therefore we are. No, you are, and that defines what you can take care of. If a patient with a gunshot wound is brought into your emergency room and you're not a level 1 trauma center, that patient is not cared for in your emergency room. She's stabilized and transferred, right? And we don't do that very well in OB. So they had a lot of good intentions to try and uniformly get some uniformity, some understand regionalization, make sure we know who needs to be where, just like our neonatal teams. And the reason this needs to be done, I'm going to give you a case example, not because I'm picking on the state of Illinois, but because I'm so impressed that the state of Illinois made their information public. So several years ago, when the state of Illinois decided to do statewide levels of care through their legislature, because many states have done it through their legislature. I don't know if Nebraska is it through your legislature? It's a lot. A lot of states have done that, Texas, etc. Here's our baseline, which is great. You got to know where you start to know where you need to be, right? So they published it, and this is a great example of why this was even needed. Okay, so if you look at their systems, they had basically, I think it was 86 hospitals, and of hospitals that were providing critical care to pregnant women, only 20% provide critical care for women, including an intensivist. I mean, just fundamentals, right? 13 had literally 0 resources to provide critical care and were providing critical care. Is that right? It's not right. It's not okay. But that's what's allowed when you don't have mandates, when you don't have requirements, when you don't have systems in place to say. And if moms deliver at the wrong level of care, they're going to be sicker. I mean, this is not rocket science. If you don't have resources to care for sick women, they're going to be really, really sick before everybody goes, oh my gosh, she's got to get out of here. We can't do this. This is an actual picture. This is not ChatGPT. You can see it, this emergency phone not installed. So why are we not getting these patients to the right level of care? The neonatal teams are 50 years ahead of us. Okay, I'm married to a neonatologist. I've seen a lot of what happens in NICUs. I hear on the phone a lot of what happens in NICUs. It's probably been the best thing for my MFM career because I get so much follow-up. I have such a better understanding of what happens to these babies and these families after they go home. Get the feedback. It's been a really interesting insight to see kind of both worlds. But let me tell you, in a NICU, can you imagine? You got a 26-weeker that's born, okay, and your institution is rated to take 30 weekers. Okay, so this baby's coming, and here's the conversation in the NICU. The attending says, I did this in my fellowship. We got this. Who's on staff tonight? And the nurse in charge is like, okay, we got Joan and Sue And yeah, I think they can handle this. They can handle this 26. They came from a level 3 before. They can handle it. They got this. We got this. We can keep this baby tonight. The next shift. Who can take this patient today? Anybody? I don't know how to take care of a 26-weeker. Okay, I guess we're going to have to transport the baby. We don't have anybody to take care of this 26-weeker. Does that sound familiar? That's labor and delivery. That's OB. But that never happens in a NICU because the NICU says, we don't take care of 26-weekers. We got to stabilize and transfer this baby out. Period. End of discussion. No one's outvoting anybody. They know exactly what they take care of. In OB, even if you have levels of care, you still don't know what you take care of. You know what your defined resources are, but a scope of service says what you actually take care of. So 50 years ago, our neonatal colleagues said, we're going to publish through the March of Dimes in the Green Journal, OBGYN, okay, Obstetrics and Gynecology, and it was about improving, look at the title here, improving the outcome of pregnancy. What they really meant was, let's take better care of babies. The beginning of baby being prioritized over mom. Fantastic thing, needed to happen, but took us literally 40 years to catch up. There are lots of barriers, but I think lack of written scope of service is a big one. Take care of, you don't know what you don't take care of. Our NICUs know exactly what they take care of and what they don't take care of. Our trauma centers know exactly what they take care of and what they don't take care of. They know if they do head cooling or body cooling. They know if they do oscillators and they know exactly what they do. We don't. So even if you're leveled, you may not know what diagnoses you can take care of. Do you do dialysis on your unit? Do you do telemetry? Do we do all of these things? It should be written down and accessible. Another preventability thing, missed one that everybody thinks is the problem. Well, they didn't know what they were doing. It's not that. It's a big part of it, but it's not just that. Because most administrations' solution to these kind of problems, when a bad outcome happens, is go give them a lecture. Just go give them a lecture. That's going to fix it all. Lecture is very important. The didactics are very important. You have to have the foundation, but your systems should support the newest nurse with the least experience thing. Okay? And I say nurse, I mean physicians too. So by condition, the things that I'm seeing when I'm talking to people and I'm reviewing these cases, preeclampsia. Okay, like there's nothing new in preeclampsia, guys. Like literally nothing new. It's exactly the same as it was forever. Okay? We continue to miss the signs. We don't consider the diagnosis. We don't treat the severe hypertension. Sometimes we're not giving MAG, or we're delaying MAG, or we're stopping MAG in the operating room. We're not recognizing pulmonary edema because she's not in acute respiratory distress. She might just be hypoxemic requiring 2 liters. And then we send them home and have inadequate monitoring. They get readmitted or they have a stroke or something along those lines. With hemorrhage, places still not doing QBO. Still. One facility I went to go evaluate, and this was probably 2 years ago, so not like, I asked the nurses, they had this beautiful hemorrhage cart, and on the hemorrhage cart they had a stand with a binder with all their protocols and all the things in it, laminated and all pretty and all that kind of stuff. And so I just walk on the unit and I was like, do you guys do stage-based hemorrhage? And she's like, I don't understand your question. She'd never heard the term stage-based hemorrhage. So, because they clearly were not doing stage-based hemorrhage management. But from an administrative perspective, oh, they checked those boxes. They got those stage-based protocols hanging on the units, but no one knew what they were. Delay in surgical intervention and failure to transfuse appropriately. I probably should reorder this and have failure to transfuse appropriately at the top. And by appropriately, I mean not giving enough and waiting too long, and then we throw the kitchen sink at them, right? That they get 30 units, but only after they started coding and are in DIC. And now we're throwing everything at them, right? So how much blood should you give them? You keep putting blood in until blood stops coming out, period. Have you ever overtransfused someone? I've never seen anyone overtransfused, ever. Sepsis is real easy to miss until you can't miss it anymore. And then we're like, oh my gosh, it happened so fast. And all of a sudden, and no, she's been running towards that cliff for about a day. And we ignored it because she was able to communicate with us and eat breakfast and watch television and all those things. And then all of a sudden she's in shock. And now we're in shock, right? That's where your early warning signs and standardized vital signs are absolutely crucial, because if you don't see that, you're not going to implement treatment, which is very simple: fluids, labs, and antibiotics. Done. That's the treatment of sepsis. Everybody in this room can do that. You have to know to do it, and that means you have to standardize. And then septic shock, the mismanagement I see is that she gets shocky, someone gives her norepinephrine, but they haven't adequately filled the tank. You squeeze the tank without filling it, you're going to kill organs and extremities. Times where we know the patient's at high risk, we know her potential issues, and we don't do enough or anything about it. Cardiac, okay? Repaired tetralogy flow. Can she deliver at your institution? Do you know that? That's an example of a scope of service. Is it on a scope of service? Do we know, right? And should we be determining this when she gets admitted for her repeat cesarean? This should all be planned ahead, a known condition that we can risk assess for. And if you're not screening for these conditions, like the oh, by the way is the best, right? Okay, I'm going to give my best oh, by the way story. Okay, we all know, you know what those are, right? You've done all this extensive stuff and then, oh, by the way, doc, and then it's something like monumental. Okay, this is the best one. I was a resident. I've never forgotten it. So whenever my medical assistant comes in and I tell her something the patient said, she's like, she didn't tell me that. I'm like, don't take it personal. It's all good. I know how these things go. Fourth-year resident, and we had a clinic. We worked with the attendings to get surgical cases. So it was a woman. I was in the incontinence clinic, and we were going to get, basically everybody was there to determine if they were going to be a candidate for a vaginal hysterectomy and all the procedures that get done to treat prolapse and incontinence. And I spent an hour with this woman, diagnosing and getting history and all the things, and doing an exam and on and on and on. And I go to my attending and I'm like, okay, I think I got a great candidate for surgery, on and on and on. I'm presenting the case and he's like, all right, let's go in. We go in, we sit down. He literally sits down and he goes, so I understand you're having an issue that you lose urine when you cough. I can't tell the story with a straight face because it kills me every time. She's like, yeah, but I think that's going to get better when I get my lung transplant. Came out of her mouth. Well, why don't you come back to transplant? And walks out. And I'm like, what just happened here? Like, good candidate for surgery. Communication. I am not talking about closed loop communication. That's my pet peeve. Closed loop communication. Everyone's screaming in an emergency, back and forth at each other. That's not what I'm talking about here. I'm talking about recognizing things and communicating them effectively, and that takes practice. You have to practice together. When the only people doing simulation are nurses, when we do simulation with a group and the nurses are starting to order meds. Simulations, they don't have physicians as part of it, physician roles. Is that enough? And you're going to get into an emergency situation, and that's what you're going to start doing. You have to have interprofessional simulation. Teams understand what other team members need. If a lot of the frustrations and challenges that happen in these emergency and high-risk situations are because team members maybe feel like they're not need to do their job, or they don't know exactly what their job is. And if the team doesn't practice together and debrief together, you miss those opportunities, what everybody needs. Okay. Role of hospitalist. I could give a whole lecture on this. If I review a case and there's been a bad outcome, hospitalist in that facility, I want to know all about that hospitalist. And that's whether I'm plaintiff or defense. I do both sides. I want to know all about that hospitalist. Who employs them? What's their role? Do they know their role? Because it's very hard to explain someone trying to die in room 10 and a hospitalist in a call room, because the private OBs didn't want the hospitalist touching their patient. Okay, that's very hard to explain. So role of hospitalists is absolutely crucial. It's nationwide, okay? Interact, I mean, documentation is a whole thing, but if you've got a spidey sense that there's a problem, then something needs to happen. Some assessment needs to take place. And that doesn't mean that as a nurse, you need to call the doctor every single time. You might call a trusted colleague or your charge nurse or somebody to give you another perspective. Say, hey, can you help me do this assessment? I'm not sure, am I missing something? And then if you have standardized criteria, then if something falls out on the assessment, you know exactly what needs to happen from there. Nurses are not doctors. They cannot diagnose or treat. And I don't like, attorneys like to make it so that the nurse should have done this and the nurse should have done that. And don't you want to advocate for your patient and on and on and on? Yes, all those things are true, but nurses are not doctors. They cannot diagnose and treat. And that's why physicians have to be at the bedside in certain scenarios, not in every scenario, in certain scenarios. So from my perspective, this boils down to some key themes of lack of standardization. And that is from who to call, how to call, what do we take care of, where do we take care of it, standardized. Everything that can be standardized should be standardized. Lack of practice. If you're not practicing it, you're not ready for it. Like when COVID hit, this was really striking to us. Like one of my partners pointed this out, and it was like a major aha moment for me. Right? And sports come to a grinding halt. I know this was a big deal for a lot of people. I'm told this happened. But when it came time to start back up again, that was the big issue. And why was it a big issue? Practice. The team was willing to go play a game without practice. Very low in terms of health and well-being, right? High in terms of money. But these teams were not willing to go play a game without sufficient practice. Yet we are willing to walk into an emergency and just wing it. Hope we figure it out in real time, right? But they literally would not play without practice, which is kind of like, wow, like that was a big aha for me. And then systemic issues. You can't fix the systemic issues at the bedside. You can just take care of the patient in front of you. That's a bigger picture, a bigger problem. And I think people get paralyzed with this whole issue thinking, well, I can't fix access, so why even bother? It feels like too much, but you can do it one patient at a time. Contributing factors, it's beyond the scope of what we can talk about here today, bias and resources and, unit culture. All these things impact how we care for patients. But I think the things that I pointed out hopefully are things that you can action on today. So with that, I hope I didn't go too long, and I'm happy to take any questions.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.